have quite a few slides to get through this morning, and I didn't quite do a recap. So we're just going to be going through where we started from. Dr. Gichoya, we're going to share screen here. Please do not, don't judge me from, oh, hold on. Let's just stop sharing for a minute.
Oh, Nigerian princess, $10,000 there. I'm kidding.
Share screen. Give me 1 second. I'm not quite as ready as I should be here, and I have lots of other things on my screen. That's the problem. I need to close those out, and then this is a slide. I'll just keep that here.
Okay. No, that's screen share. This is why I work for Dr. Newsome, to fix her IT problems. Okay, yeah, you can.
All right, wait a minute. Hold on. Share screen, desktop, share, and here we go.
Awesome.
All right, can you see the screen, everyone? Fantastic. So we're going to carry on. This fantastic picture that you're looking at is the front lawn of the Emory School of Medicine. We deface this frequently by just standing there and doing all kinds of stuff, but it was built recently and over the last 15 years. So lots of people are not really, if you've been at Emory beforehand, maybe not anybody on this, but they'll say, well, we've never seen those pretty buildings before. Those are new. And I continue to inspire as well as to instruct, and to let everyone know as well, as I shared last week, that we are all giraffes here, but we recognize that in our midst, always, that there will be turtles, and they're a part of our ecosystem, but we will not take any advice from turtles who are not able to see far above the shrubs as we're able to see far into the trees. And so let's see if we can do this journey together. So we're going to continue on our arterial vascular anatomy. I think last week we did quite a bit of coverage in the, chest region, and now we're into the abdomen. So normal vascular anatomy into the abdomen, I think as we were looking at the singular arteries, we thought that we would have the celiac artery or celiac axis, the superior mesenteric artery, and the inferior mesenteric artery. But let's go back a little bit and look at what we consider the celiac anatomy. The celiac anatomy consists of the splenic artery, the left gastric artery, and the hepatic artery. The superior mesenteric artery anatomy, we'll go into all of these with more detail, but just wanted to make sure that we're recognizing that these are the three arteries that we'll be talking about. Now, with imaging so rampant, Walter, like everyone is getting a CT scan and MIP images, so we are able to see this anatomy and their variant branches, quite frequently. So knowledge of what the normal anatomy is and what the nomenclature is very, very important, because everybody can get a CT and everybody can get an ultrasound now. So you can see beautifully displayed here the artery, the left gastric artery, the common hepatic artery, the gastroduodenal artery, right and left hepatics, and the superior mesenteric artery, which is your image to the left, and imaging to the right clearly shows that this is an aberrant anatomy, right? You can see that the superior mesenteric artery is here and the right hepatic artery arising from the superior mesenteric artery instead of from the celiac axis, a very, very common variant. And we'll talk about the significance of that. So the reason that knowing the visceral anatomy is important is not just for eye testing, right? So I like being able to bring this back to some, practical use. And so one of the things that we deal with quite commonly is GI bleeding, someone that just shows up to the emergency room or, at home with GI bleed. It's a very, very common problem. Lots of people that are hospitalized for that. And although we have lots of things to treat that, the mortality rate has not changed over the last 50 years. Around 10% of people would die from a GI bleed already. So the diagnosis and treatment for acute GI bleed, though, has changed over the last few decades. And we have been pushing the envelope for this more and more, especially at Emory, trying to change the paradigm for the things that we were used to do for diagnosing GI bleeds. Versus now, and then the widespread use of H2 blockers. Everybody that comes into the ER is on some kind of H2 blocker. They're on cimetidine or Pepcid or something like that. And although we have colonoscopy and upper endoscopies, angiography, right, putting a catheter in and trying to see exactly where the blood vessels are going, is still very much required in these problem-solving situations.
I just want to put in a plug for some words that Dr. Newsome said there, H2 blockers, right? So with time, we're going to integrate more pharmacology into this, but it wasn't really common, so sorry if now it's common, but there are these prophylactic medications that are given to patients when they're admitted. So always think about like DVT prophylaxis or, ulcer prophylaxis, right? Because if you develop a perforated ulcer in the hospital because you've had a prolonged hospitalization, that's a pretty disastrous effect. So just keep in your mind that may be in the stem of a question, or that's really, I'm not going to go to the data around peptic ulcer prevention prophylaxis, but this is pretty common. Now, when I was doing my internship in Kenya Even Medical School, most of the staff were around. When you saw an ulcer, it really was because of, like a duodenal ulcer or a gastric ulcer. And we're going to get to the pathology, like GI pathology, where we'll discuss ulcers and some things that are related to that.
Fantastic. So if you take, we're again just talking about arteriovascular anatomy and its significance, right? So I'm not going to pay that much attention to this image to the left, but you're probably already looking at it and you're like, geez, Dr. Newsome, I can see here that something is already wrong. It says the CA, not the celiac axis, was excised in this patient. And here you can see that the superior mesenteric artery is still patent. And we may have Dr. Gichoya a few weeks ago, when she was showing off her case of embolization, talked about this front door, back door, this arcade, this rich arcade that's around the duodenum, where you can have, the vasculature reconstitute or collateralize through the inferior pancreatic or duodenal artery back up to the gastroduodenal artery, and then still feed the liver. And this is a beautiful picture of that. But let's carry on. So back to the clinical aspect, because I think that this is what really drives the need to remember this anatomy, right? So when someone comes in with acute GI bleed, when you see them in the ER, you're going to be thinking, okay, they're hypotensive, right? And this concept of orthostatic hypotension, that you see that when someone's blood pressure changes from laying down to sitting up, where we see that when there's around 20% loss in their blood volume, or around 1,500 cc's. Or when someone now is hypotensive and is tachycardic or in shock, that's someone that has lost around 40% of their blood volume. So you're already recognizing from your clinical evaluation of someone, how much blood have they lost already? And now it is our turn to try to figure out where bleeding may be coming from. Keep in mind this very salient point, Walter, that the H&H may not change for a few hours after the bleed. So if you have a massive bleed at home, and you come to the ER right away, and someone says, well, the H&H is stable, but you're hypotensive or having orthostatic, what you should really pay attention to is the physiological changes, such as the hypotension and the tachycardia, even though the H&H may not be as reflective right away. So angiography, and again, I'm not going to pay too much about that, but just note that it is used to exactly determine what is the site of bleeding. And sometimes this can be done endoscopically, so that they say, okay, fine, I've put a scope in, I don't see any blood in the stomach, but I see blood coming back from the duodenum into the stomach. Or that it says, well, geez, I've put a scope in and I see big varices, and I know that this person is bleeding not from an arterial source, but from a venous source. And we're going to get to that, but probably not even today. But angiography can detect bleeding as low as 0.5 cc's per minute. And that is very dependent on how close your catheter is. And we're not doing this just for, looking at its sake, but now you can actually treat the site of bleeding by injecting different embolic agents. And the rate of bleeding, again, is, you can see in angiography, we can detect things as low as 0.5 cc's per minute, but you may be asked in exams or have been told that if you get a nuclear medicine radio-labeled red cell scan, that is a very, very sensitive scan and can detect bleeding as low as 0.1 cc's per minute. And now we're changing the paradigm, Walter, so that even patients will not even need to have this tag red cell scans anymore, but they will come to CT angiography that not only gives us the information about the vasculature, but will tell us, other things that are around it. And here are the different type of embolic agents that we could inject inside the blood vessels to try to stop the bleeding. These are coils, and some of our coils have materials on them, and those materials can be used to, the material is used to accelerate the coagulation process. The image that you see here is a syringe with particles that are also injected within the bloodstream. These are particles as well. This is a syringe of just gel foam, which is very, very cheap, that we can make into slurry or torpedoes to stop bleeding. And I want to point out that the first set of embolizations that were done for bleeding were done in the setting of trauma. And it was indeed the patient's own autologous blood that was used to clot off and then injected back into the patient as a way of stopping the bleeding. Let's look at some cases to point out this vascular anatomy again. So upper GI bleed. This is a 74-year-old that came in.
So Dr. Newsome, what's an upper GI bleed?
So an upper GI bleed is someone that is having blood from, throwing up, blood. Is that good enough? Okay, I'm sorry. Dr. Gichoya wants me to use the term hematemesis. So upper GI bleed is hematemesis.
Coffee ground emesis.
Coffee ground emesis.
Sorry, there's also a dog here called Simba who's also having emesis right now. But and the demarcation for upper versus lower anatomically is at what point?
Right, so you can put that in the chat. Can you, if you know the answer to that, if you can put that in the chat. What is the demarcation for upper versus lower GI bleed?
Yeah, and I haven't been doing a good job. There's a question here, what is H&H?
What is H&H? So the H&H stands for the hemoglobin and hematocrit, right? So it's, I don't know if the same thing is used, yeah, the hemoglobin or the hematocrit.
Okay, lots of answers saying ligament of
ligament, that is incredible. So that is the demarcation between upper and lower GI bleed. Keep in mind, because that was one of my questions coming up later on, what is the main reason for upper GI bleed? And what is the main reason for lower GI bleed? Okay, you can put that in the chat. Dr. Gichoya will help me. But this particular patient came in with hematemesis, had endoscopy twice during this admission, and they were found to have blood seen in the post-bulbar duodenum. No ulcerations were identified. The patient went to the ICU. Their hemoglobin was, low after they have gotten 4 units of blood, right? So here we go. We know that this is going to be bleeding somewhere in the celiac axis territory. So angiography was performed, and I've pointed it out here. LG standing for the left gastric. You can't see it that much, but coming up here, this would be the splenic. I have an exam question coming up for chat, so just pay attention to what the arterial anatomy looks like on angiography. Not the same as in Netter, but close, right? You can see the common hepatic artery, CH, the gastroduodenal artery. After the gastroduodenal artery comes off, then you will have the proper hepatic artery that then gives the right and left hepatic artery. This S belonged up here, and this should be the right gastroepiploic artery. That's just a problem with movement. Okay.
So the answers to the upper GI question, you have a couple. There's peptic ulcer disease, varices, bleeding esophageal varices, portal hypertension, stomach ulcers, GU, which I think is gastric ulcers, varices, and the first answer for lower GI bleed is diverticulitis.
Oh, that's awesome. So I would say that all of those answers are correct, but in the spirit of Walter, I'd say the best answer is going to be for upper GI bleed is peptic ulcer disease, is ulcer disease. And the most common source of an acute lower GI bleed, ding, 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 is a very fast upper GI bleed. Because upper GI bleeds actually tend to be so much more common than lower GI bleeds that you must exclude a very fast upper GI bleed being the cause of bright red blood per rectum and not just a true lower GI source. Also, kind of an exam question, just keep that in the back of your mind. You're right that diverticular disease is the most common cause of lower GI bleed of the lower GI source, but bright red blood per rectum, the most common reason is a very fast upper GI bleed. All right, let's go on. So in this particular patient, I forgot to put the numbers here, which was supposed to get you to tell me what this is, right? So I'm just gonna put the arrow. I don't know if you can see the arrow sign here. So on my arrows here, please, if you can put in the chat now, what is the name of that blood vessel? Dr. Gichoya, please leave my arrow alone. Right here. Okay, what blood vessel is this? Common hepatic. What blood vessel is this? Where my arrow is pointing to right now.
GD.
GDA,
Oh,
gastroduodenal artery. Fantastic, okay? All right, what about this blood vessel here? One of the main branches of the celiac. Splenic artery. Fantastic. How about this vessel here? The main culprit in people that have gastric bleeding, like from bleeding from the stomach. If you saw that someone was having pure gastric bleeding, you should be looking for the left gastric artery, right? LGA, left gastric artery. And then the continuation, this is the right gastroepiploic artery. And then after you, after the gastroduodenal artery comes off, what is this vessel called? Dr. Gichoya? The proper hepatic artery. Okay, good.
But people are saying that.
All right, I know, but you have to tell me because I can't see the chat. Okay, so I am, we're beyond that point now. So because this patient had bleeding in the post-bulbar duodenum, we know that this is in the vascular territory of the gastroduodenal artery. And so this patient was treated with coils here in the gastroduodenal artery. And let's see what happened. Here are the coils all the way up. Here's a catheter again, where you can see the in the celiac artery, the gastroduodenal artery has been excluded with coils, and now there's good flow into the liver, and this patient just stopped bleeding, was able to be discharged from the ICU in 48 hours. Another patient, just to bring the point home again, that this patient came in with massive upper GI bleed, has had a prior upper GI bleed before, and has a known duodenal ulcer. So they're like, okay, fine, you know what, we're taking this patient to the operating room, we're going to oversew this ulcer. The patient had the operation, went to the ICU, and while there, developed a DVT, right? So what's a DVT? A deep venous thrombus, a blood clot in the leg that happens from immobility. And because the patient had this GI bleed, the patient was not able to receive anticoagulation. The patient had a filter. Now, do you know what a filter is? It's like an umbrella that strains the blood to catch all the blood clots that from the DVT before it could get to the heart or lungs. But while the patient was in the ICU, they developed another upper GI bleed. The patient became hemodynamically unstable, got a lot of units of blood and blood products, so came to angiography. You can see a few things from the pictures here.
Before we go to the pictures, I just want to reemphasize a little bit. Sometimes, examiners like to ask, what's the next step? Right?
What is the next step?
Yeah, immediate next step, right? So if you find someone with massive, the vital signs are all over the place, then the next step should be resuscitation, right? You should make sure that they have, and in life, right? So the next step should be that you're making sure they have large bore bilateral IVs, you're getting blood cross-matched. They have, commonly do massive transfusions. We'll go through that when we review hematology a little more, but just know that this is something that you have to always be keen to figure out, are they asking me for the immediate next step, right? Don't overthink the questions, but if it's the immediate next step, it could be that, before you send someone to endoscopy, and you can also look at the answer choices. If the answer choices are saying, oh, the immediate next step is an IV line, or, the ABCs of
CA.
Do you want to explain why it's CABs?
Right. So the ABCs used to be airway, breathing and circulation, right? Am I right about that, doctor? But now it's for resuscitation, it is making sure that people are able to have their circulation first, so that's why we call it CABs. But that's outside of the scope of this talk here. When we look at this patient, right, you can see that they're staple lines because the patient just had surgery, right? A catheter is coming from the groin, from the femoral artery, and it's placed into the celiac axis. And the black represents the X-ray, the contrast that's been injected, and just like the anatomy that we've just reviewed, right? You can see the common hepatic artery, and then you can see right where the gastroduodenal artery would come off, it's been oversewn in surgery. And then you see the proper hepatic continuing off to the liver. We don't see any bleeding here. But just like Dr. Gichoya pointed out earlier, this is a unsubtracted image of the same thing, right? One beforehand, one afterwards. Here where you can see the bones have been subtracted. Here you can see where the bones have been in place. And now you can see pieces of this filter that I was talking about that they also had placed for this patient to catch their clots.
So there is a comment by Sheila, which I didn't know. Sometimes they ask the path taken by the catheter. So guys, we've been going through this quite a bit now, right? Every time we show you an angiogram, we show you, we've been showing you sort of like Dr. Newsome said, this is coming from the groin. There wouldn't be too many pathways taken, I think, overall. You just have to figure out where you are and if you're injecting the vein or the artery. So once you go to the venous system, we can tie those things up. And just remember that the anatomy, we're biased because we show you more of angiogram images, and we have some CT images too, as you saw in the previous last week's lecture. But the thing is that you just have to remember that your eyes have to be tuned to seeing the same anatomy on a CT scan or an MRI scan, because the naming will be the same.
Yeah. So what pathway did it take to get to this point, right? So because you can see the shape of the catheter, and I'm coming from the feet towards the head, it would have to be like from the right or left, common femoral artery, into the external iliac artery, into the common iliac artery, into the abdominal aorta, past the IMA, SMA, renals, and then into the celiac artery, right? I guess I missed it the other way. It should be IMA, renals, SMA, celiac artery. That would be the pathway coming from the groin. I'm glad you mentioned that. That way I could pay a little bit of attention to this. So we don't see any extravasation here, no bleeding, Walter. But we know that there's a rich arcade of vessels that supply that duodenum. So we've got to look at the back door, the inferior pancreatic or duodenal artery that would be coming off the SMA. So this is an unsubtracted image. Again, here you can see the catheter come in all the way up, and this is in the superior mesenteric artery. And here you can see that inferior pancreatic duodenal artery branch. And I'm going to show you all the paths that was taken in order to get to where we were able to place a microcatheter that would demonstrate the bleed and where coils were placed. So this arrow is misplaced because we magnified the images here. But here you can see this is a catheter in the SMA and a smaller catheter out here that shows a bleed all the way out there, right? Here's the microcatheter all the way out. And now we can place coils, to stop the bleeding. Right, microcoils, microcatheter. So knowledge of the vascular anatomy is not just for asking these questions, but it is critical as it relates to treating patients that come in with either upper GI bleed or lower GI bleed. Questions, please put them in the chat if you have any.
The coils act by having the anticoagulant substance on them?
Oh, that's a great question. So there are two ways that the coils work. These coils that were placed actually work by just the physical blocking of the blood vessel, having the coil there. But some of the coils have materials on it, dacron, and they actually serve to accelerate the coagulation cascade that cause platelets to become more adherent, and then it forms a clot, right? So that's how coils work. We have other coils now in the market that do not depend on the coagulation cascade at all. Because if you can imagine someone that has like a massive transfusion, they don't have much of their own blood inside of them. They start going into this DIC, disseminated intravascular coagulopathy profile, where they don't have enough functioning platelets to form a clot. And so we're able to put other coils there that expand the blood vessels that are coated with hydrogel. And then when they're at body temperature, they will then expand into the blood vessel and then block that blood vessel off. So the technology keeps evolving, and they're in the situation of trauma, or even in a case like this, you may hear where we're able to do what's called like a gel foam sandwich, where we'll put coils and then gel foam and then coils on the back end of it. I think of it as by any means necessary to try to stop the bleeding. All right, I want to show you another case to just, kill this dead horse already. A 42-year-old patient with gallstone pancreatitis. So if you can put in the chat, what would you expect this patient's enzymes to look like? What would you expect this patient's blood work to look like? The patient presents with gallstone pancreatitis, and in the past has had stone extraction. The patient had ERCP, and now everyone knows there's a drop in the H and H. So you're like thinking, okay, gallstone pancreatitis.
Funguses, amylase and lipase.
Amylase and lipase would be perfect. So now you're expected that, but why the drop in the hemoglobin or hematocrit? Now this patient had endoscopy again, and they're like, we don't really see anything, no ulcers or anything, but we see this active bleeding into the duodenum. And so the imaging workup. Now, does anyone know what this picture is showing? And I understand that you may not know. So this is a picture of a endoscope and then through the endoscope, they are able to place a basket in through the duct. So this is not in the blood vessel, this is in the bile duct. Because remember, this patient had gallstone, pancreatitis, had stone extraction, and this is a picture of the stone extraction, right? So here's the endoscope, here's a basket through the ducts, here's the little basket that is out here, and we don't see exactly the stone because it's probably being covered by the scope here, but it's where you would see like a fill-in defect. Then afterwards, this is the imaging workup where the patient now had endoscopy again. They saw blood coming into the duodenum. Remember, this patient is not doing very well at all. And on the CT scan, you can see the spleen on the left. Here's the liver. You can see that this is the aorta. We expect the intrahepatic IVC, inferior vena cava, to be here.
What's the diagnosis?
Okay, so I already put an arrow there and I say, suspicious, like
Because
what do you think this
about
is?
This
okay,
in the past.
how we have talked about this in the past, but I wouldn't be, what do you think that round thing is in the liver? It is not a duplicated aorta, I hope not, or a duplicated IVC, but in the interest of time, put your answer in it is a pseudoaneurysm. Perfect. So this is a hepatic artery pseudoaneurysm. And here you can see our catheter again making that same path from the groin, right common femoral artery, right external iliac artery, right common iliac artery, into the aorta, passing all those branch vessels into the celiac axis, into the proper hepatic artery. Am I in the proper hepatic artery now? Where is this catheter located? It's before the GDA. And then you can see the nice big hepatic pseudoaneurysm. How to treat it? Here, the microcatheter is into the selective right hepatic artery. You can see this beautiful blush of the pseudoaneurysm. One would think that Dr. Gichoya is doing this case, and this patient had embolization and did well, no further bleeding. These arrows were supposed to be me trying to trick you guys and test you by saying, what is that branch and that, but there's no tricking you guys now, you're all about it. Okay. Are we done with upper GI bleeds? Not really, because we didn't talk about the jejunal branches of the SMA, but I'm going to come back to that. Let's talk about lower GI bleeds. So lower GI bleeds account for around 20% of all acute GI bleeds. So that means that 80% are upper GI bleeds. And remember what I told you before, the most common cause of acute bright red blood per rectum, you've got to think about a very fast upper GI bleed since they're so common. Most lower GI bleeds are in elderly patients, and they stop spontaneously because they're from just diverticular disease. But following investigation, a cause most of the times can't be found. We're like, oh, this patient had a lower GI bleed. It wasn't bright red blood per rectum. It's just an occult blood, but not necessarily blight. And a lot of times nothing is found. I think we've talked about this before in terms of the most common sites for GI bleed of the lower kind, the cecum, descending colon, and the rectosigmoid region. So Dr. Gichoya wants to jump in here.
Yeah, so I hope that Dr. Newsome is going to recap the blood supply for the lower GI bleed and specifically this systemic, and not too much into details for that because we have more slides for future about it, but especially looking at the rectum and how it's applied by two different systems, because that's going to set us up for future lecture in terms of this photosystemic communication.
I do not have any slides about that this time around, but maybe this will help just a little bit, right? So the blood supply to the that is responsible for lower GI bleed, given that the upper GI, lower GI demarcation was by the ligament of Treitz, it clearly involves both the superior mesenteric artery and the inferior mesenteric artery. Dr. Gichoya is nodding her head. What do you want to say here?
So
I'm going to get some more coffee.
Okay. So in this section, I didn't ask, right? So we said upper GI bleed, ligament of Treitz, right? So where does that come from embryologically? Could a few people put it in the chat, right? So we have foregut, midgut, hindgut, right? That's sort of like the hint. And I know I'll move over for Dr. Newsome to speak soon, but yeah, so foregut, right? So you're thinking, I just want you to tie sort of the concept where you're now thinking, okay, if I'm thinking embryologically, or this is a question that's sort of like it's supposed to help you figure out where you are and where the blood supply goes by, that you can still relate those two. So where is the demarcation between the mid and hindgut in terms of embryology?
I'm so glad that you're asking others that question. I don't know if I know that answer.
You know, and so it really comes close to the demarcation of exactly, right, in the transverse colon, right, where we have the watershed area that's applied on the right side, and then I think it's right 2/3 and left 1/3.
Fantastic, Sheila.
Yeah.
Perfect.
Yeah, it's around the splenic flexion. Exactly. Yeah. And so that's sort of like the basis of this SMA supply, right? And I like to remember them by thinking of an MRI, and that's just because I'm a radiologist, right? So you start with the middle colic, right? And then remember the handedness. We say this is the right side of the patient, this is the left side of the patient. So if you have another colic, then it's a right colic. So M for middle colic, right for right colic, and the long branch that always goes down, that appears to be the last branch of the SMA, is usually the ileocolic. And then Dr. Newsome can go ahead.
Fantastic. So MRI, middle colic, right colic, ileocolic. And the branches for the IMA, we'll talk about that a little bit better when we look at some patients, because I tend to think that when we tie this to a patient situation, it may be a little bit easier. But you can see here from the inferior mesenteric artery that it actually has most of the left colic branches, but you see that nice rich arcade that comes back into the anastomosis with the middle colic. Dr.
Do not ask me.
No, are you trying to say something?
No.
Do you have a mnemonic for this?
No.
Okay, I thought she was going to have a mnemonic like the MRI, but apparently she won't. Let's look at a patient that will help us to think about this the blood supply. Okay, so 43-year-old, multiple episodes of melena, right? So melena is different than hematemesis, right? So someone that has melena, what does that mean? The patient is chronically anemic, has had multiple prior upper GIs and lower GI endoscopy. What's the answer, Dr.?
Oh no, Sheila just said she liked that MRI.
Oh, Sheila likes the MRI. Sheila, that's called sucking up. So this patient, though, an admission had a life-threatening bleed, right? They requested an angio. They were like, okay, we're not going to need to get a nuclear medicine scan because this patient has been bleeding and bleeding a lot. All right, so when we look at this angiogram, and you can't tell here, but this is also coming from the groin, right? This catheter is in the superior mesenteric artery. This is clear as day, and I won't even get you to say what you think this is, right? This is like a big bleed from one of the jejunal branches. So we actually were able to super select that jejunal branch, find one of these bleeds, and I'm not making any of you guys into an angiographer, so I do not want to be here talking about how many vessels you can take out before you're creating ischemia. But I do want to point out the arterial anatomy, that if this is the celiac axis, right, if you are looking at what Dr. Gichoya was saying, that you would expect there's a middle colic here, right? I don't have it labeled. The right colic for the R, and the longest and terminal branch of the superior mesenteric artery is called the iliocolic, and all the other branches are going to be jejunal branches, and you could refer to them as jejunal 1, jejunal 2, jejunal 3. When you splay out the gut, which is the image on your left, on your right, sorry, keep making my left and right-handedness. On the body, when I read, this is considered the left side, so you can see that rich arcade of blood vessels that supply the intestines. But there are also quite terminal branches when you look at the very end. This is to make a point for embolization, not meant to be talked about here. So just look at this other case of the 68-year-old male who came to the ER with brisk bleeding, bright red blood per rectum, and everyone says, I think the reason for this is I need to exclude a very fast upper GI bleed. The patient had a positive nuclear medicine scan somewhere in the right upper quadrant. So if you're thinking, okay, what blood supply could that be? Okay, now I'm gonna give you some more information. This patient had a negative colonoscopy, lower endoscopy. So now you're, maybe this is something a little bit higher up from not in the colon, but they're just oozing to where now we're seeing this coming from the rectum. Oh, but then on day number 3, the patient had a massive life-threatening bleed. And now they call, what can you guys do to help? Remember, this patient had already been in the hospital. And so we do this angiogram, and you can see a catheter, maybe not, you can't see as well. This is a subtracted image and unsubtracted image. A catheter is coming from the groin. It's a what we would call a pigtail catheter. It's placed above the celiac axis. And so you can see the entire aorta and iliac branches, the black that is being displayed for where the blood vessel is. So if we recap here, you can think that this would be the celiac axis. This would be the splenic artery here where my arrow is pointing, hepatic artery. I know that this is the opening or ostium of the superior mesenteric artery. We don't see it that well. These are the blushing from the kidneys. So right and left renal arteries. This is the aorta. Right and left common iliac arteries, and you're like looking at this saying, boy, I don't really see anything. But remember, on a previous slide, I said that when you just do non-selective angiography, you have to be bleeding at 6 or 10 cc's per minute in order to see that. This patient may not be bleeding quite as fast, but we know exactly where this nuclear medicine gave us a hint of where this may be coming from. So if we go back to our netter image and we thought, okay, fine, we're going to select the superior mesenteric artery, we can see Dr. Gichoya's MRA that you were saying here, you know, for the middle colic artery, right colic artery, and the iliocolic artery, and all these other branches being jejunal branches, okay? The netter image, if you look at this is the SMA, right, middle colic, right colic, iliocolic. Am I saying that right? Yep. And iliocolic. Right colic is labeled here, and then the terminal branch being the iliocolic, and all of these just being jejunal branches. So just to kill a dead horse again, catheters in the SMA, jejunal branches, middle colic, right colic, iliocolic. So we had a big hint from the nuclear medicine scan that this is going to be a bleed in the right upper quadrant. So we're going to go right to the right colic artery. So you can see this catheter now, microcatheter in the right colic artery. And once you're super selective, here you can see the active bleeding into the colon in this patient. And so this is a different type of image play where we're able to reverse black versus white. And you can also see, you know, from prior clips that were done on this patient, but we were able to put coils in. The patient just did fantastic and was able to be discharged home, did great. All right, I'm gonna go even faster. Okay, bright red blood per rectum, anyway. Just know that Dr. Gichoya may take the floor now and just talk about the rectal blood supply, but it's important that we try to mirror this vascular anatomy to what you're seeing when you see a patient. When patients come in, they're not going to be telling you, oh, this is I think I'm bleeding from my superior rectal artery. But from what is happening with the patient, you get a sense as to, is this blood, when did it start? Did it just, is it bright red? Have you ever had this before? But, and you're able to, through the clinical exam, through the history and some of your diagnostic imaging, figure out how you can actually help this patient from a minimum approach so that you can stop their bleeding. So the blood supply to the rectum, again, is branches from the inferior mesenteric artery. And you can see that there's also a very rich arcade from the rectosigmoid arteries that give off the superior rectal artery. The middle rectal artery and inferior rectal artery also supply the rectum. We're going to exclude the rectal artery branches supply right now, just to focus a little bit on the IMA, since the inferior mesenteric artery, since I want to kind of expose a little bit of other causes of the lower GI bleed. So
there's a question. Is it possible to have a fast bleed manifest rectally with absence of hematemesis?
Yes. Yes, absolutely, absolutely possible. So the IMA is, again, has a downward going branch, and then these upward going branches mostly supplying the descending colon. It has again, ascending branch of the IMA, descending branches of the IMA, and that actually arcades with the middle colic artery that around the splenic flexure. This particular patient, again, I forgot to put my numbers here. I was going to be trying to have you guys say what these branches are, but I don't think I can trick you, right? This is the IMA. This, again, is the ascending branch of the inferior mesenteric artery. This would be the descending branch, the ascending and descending branch, given these are the branches that are in the rectosigmoid region. And what is SH? Does anybody know? Put it in the chat if you know what the SH stands for. Dr. Gichoya was giving some hints to that earlier when she talked about the rich arcade of blood that's in the rectum. So nothing in the chat yet. Okay. Maybe it's superior something, right? So I guess I messed it up by putting the H here, referring to hemorrhoidal. It is the superior rectal, and it really should not be superior hemorrhoidal, but those are also the branches that are now referred to as the superior hemorrhoidal branches. This particular patient actually had such a distal bleed. They were just bleeding from hemorrhoids, and that's what we ended up doing. We actually, no embolization was done. We sedated the patient, sent them back to be treated endoscopically, and they were able to just clip these hemorrhoidal branches. I'm going to take 2 more seconds. Dr. Gichoya is going to take the rest of the floor just to talk about diseases that arise from the renal arteries. Since we're talking about the arterial anatomy, just remember the renals are paired, that they come off somewhere between the L1 and L2 interspace. A vast majority of people have just one left and one right, but remember, you can have duplicated renal arteries, and sometimes you can have triplicated renal arteries. I will not go through the anatomy beyond the main renal arteries, but if you are going to be my fellow, then you would have to know these segmental arterial branches. Again, want to emphasize that CT is now so rampant, and it's being used and can be used in multiple projections to show the normal renal arteries in someone. So this is someone, a 39-year-old that had long-standing hypertension and had a CT that looking for renal artery stenosis. And you can see here, there's no renal artery stenosis. This is a 62-year-old person that we're evaluating for a living donor. and knowledge of what these renal artery branches are is like critical, so that when they go in to do the operation to take the kidney, that they'll know how many renal arteries there could be, and where should they perform the clamping. And especially if this is going to be the kidney that they're donating to someone, they will need to prepare the donor for receiving these 2 branches versus just a single branch. Catheter angiography was done routinely in the past, but now these are almost always done with CT angiography. But let's go back to another thing that we can treat for someone that has renal artery disease, right? So this is someone that has renal artery stenosis, typically can be found on ultrasound, Doppler exam, CT, or MRI. Usually, MRI is the mainstay now, and Doppler exams for diagnosing renal artery stenosis, and several of these patients will actually have changes in their creatinine, right? So that they don't want to get iodinated contrast. Write your questions in the chat if you have them, I will take them. Okay, so this is a patient of mine. It's a part of my coulda, shoulda, woulda, and I'm going to stop after this case. This is a young man who had been stabbed several times, went to the CT scanner, and was seen to have this, injury to his left kidney. Here you can see a lot of, blood around that left kidney. The patient, again, axial imaging showing, that renal injury. The patient was taken to the operating room, and they worked for 3 hours just to try to stop the bleeding. And they took everything that was in that left side of the body because it just kept bleeding. They took the left kidney, it bled. They took the spleen, it continued to bleed. They did a gastric resection, and it still bled. They took a part of the splenic flexure of the colon, and it still bled. They took out the whole, and it was still bleeding. They'd given so many units of blood, they could not stop this patient from just oozing and oozing from that left side. And so they called Dr. Gichoya, is there something that you guys could do to help us with this patient? And then you can't really pay attention to it here. These are packings that were left inside the patient, just packed into the left upper quadrant. And I wanted this to be able to play, but it didn't play. But I could show you on these subtracted images that we were able to help this patient and stop this patient from bleeding right away, because what they didn't know is that this patient had 3 renal arteries. 3 renal arteries. You can see one here, this is the second one there, and the third one here. During the operation, they actually tied off 1 renal artery, took the left kidney out, and this patient kept bleeding and bleeding from the stump of their other renal arteries that was not identified in someone that was just oozing in that left upper quadrant. So we were able to find these other 3 renal arteries and stop. It would have been perfect if on imaging beforehand, someone would have been able to say, okay, there are 3 renal arteries on the left, so that people would be able to know a little bit more about that. Clearly, this patient lost a lot of blood, got a lot of contrast, and ended up having contrast-induced nephropathy. I don't want to spend time talking about that right now, but you may see questions about that, right? Which is why we check the creatinine on patients before they receive, iodinated contrast, for the fear that not just because they get a certain amount of contrast, but when you tie that with someone that is hypotensive, hypovolemic, and all these contrasts, they're at significantly higher risk of having contrast-induced nephropathy. Now, very few people are dying just because of that, but it increases length of stay, and the need for dialysis is rare. Although patients will require some peri-event dialysis, long-term dialysis in a normal patient would be rare. So this patient did great. By hospital day 3 or 7, the patient had their normal kidney function and left the hospital doing fine. I mean, I learned a very important lesson from this, and this is always a part of my coulda, shoulda, woulda, right? Like, This patient already had a CT scan beforehand, right? And went to the OR, lost a lot of blood. And I could have tried alternative contrast use, such as CO2, but I was looking a lot. I shot an aortogram, gave a lot of contrast, trying to figure this patient out. I should have optimized the patient a little bit more clinically, maybe gave him some nephroprotective medications and consulted nephrology earlier. But instead, I actually just did my thing, and then the patient's creatinine really went up quite dramatically and ended up doing well.
So very high yield information around contrast-induced nephropathy and how to prevent it.
Okay, I'm done. Dr. Gichoya is going to, okay, I'll just keep going here. I'll show you two more of my cases. So hypertension, right? And I don't want to go through it, but I could, right? This entire renin-angiotensin pathway and how that helps to, how hypertension is induced by renal artery stenosis. If you know how that is, and if you can please type in the chat that entire renin-angiotensin pathway, why does renal artery stenosis cause hypertension? I will look at those answers in a minute. Just know that it is extremely prevalent, but that the renovascular cause of hypertension is actually quite low. But although it is low, because hypertension affects so many people, why wouldn't we want to try to figure out if there is a treatable, curable cause for hypertension? Why don't we do it? Let's look at this particular patient. I'm looking for the answers in the chat. What is how does the renin-angiotensin pathway contribute to hypertension?
So RAS, stenosis triggers RAS. And RAS causes hypoperfusion of the kidney.
And then what happens after that? Okay.
Then, oh, I like this because many people.
Okay, keep telling me. Keep telling me.
So
and then.
It leads to increased renal perfusion, which triggers renin release.
So there's decreased renal perfusion. The body thinks that now I am not able to filter, like the kidney can't see that. So it thinks that it needs to increase the blood pressure, so it has renin release. Then what happens next, Dr. Gichoya?
So
the answer saying
causes vasoconstriction.
Oh, perfect. So then angiotensin causes vasoconstriction, but you're not giving me another part of it, right? So where does this angiotensin come from?
Okay. So renal stenosis causes low renal perfusion, which is sensed by the JGA.
Yes. Yes, right?
Is produced
angiotensinogen, which is converted to
angiotensin 1.
Where?
Then
in the lungs, all right? And then
becomes to vasoconstriction, then increase of the
perfect. Okay, all right. Now you guys are showing off on me now. So let's just stop there. I can't even take it anymore, Walter. So here's a 59-year-old female that had coronary artery disease, chronic renal insufficiency, severe hypertension on 4 medications, still not well controlled, and her baseline creatinine is quite high. And I want to point out here that this is a reverse curve catheter coming from the groin, engaging the left renal artery. You can see that there's quite a bit of stenosis there. And then after the area of stenosis, we describe this, Walter, as post-stenotic dilatation, where the vessel beyond the area of stenosis becomes a little bit bigger and above the area of stenosis to try to, well, I guess it's because it's after the area of stenosis is increasing its capacity so that it can try to get more blood flow. This is treated very well with renal artery stenting that you see here on the imaging to the right. And although controversial, it can actually help patients to decrease their blood pressure. It is the patient selection that is more important than whether or not this actually works. So yes, we can do this to the left side and to the right side, and we have all kinds of different techniques. But there's another disease process besides renal artery stenosis, as in atherosclerotic disease creating blockages in the blood vessels. that can cause hypertension. And I would like you to put in the chat if you know what this diagnosis is. Another disease process that also affects the renal arteries. Okay, all right. You know what? I'm going home. All right, this is unbelievable. So this is indeed fibromuscular dysplasia that affects not the renal artery exclusively, but definitely the renal artery. Okay, so I'm not gonna belabor the point, but that you know that atherosclerotic disease is a systemic disease. It affects other diseases of the blood vessels in the body. People that have atherosclerotic disease that affect the renal arteries have atherosclerotic disease that affect the carotids. They're predisposed to strokes as well as myocardial infarction. They're predisposed to peripheral arterial disease and have claudication and sometimes rest pain and tissue loss. But this patient just had renal disease and also has peripheral signs of claudication. All right, so I'm going to try go a little bit faster now. I know that we're over time. All right, if you can tell me what syndrome does this disease state depict? So I could tell you already that this is an MRA. It is showing the heart, the aorta. You can see one kidney, and then the arrow points to something.
No answers yet.
No answers yet.
Starts with an L.
Nope, you're cheating here, phoning a friend. Starts with an L. I know that Dr. Gichoya mentioned it a few weeks ago because I was sitting next to her when she said it. And let's pretend that this is a male patient. Okay, what if I tell you that this arrow, Walter, and who are my big answers, Pauline, if that this refers, this is an...
Please repeat the question.
The question is, what is the diagnosis?
And what are the symptoms?
And what are the symptoms? This arrow points to, oh, stop it. This is too hard. This is occlusion of the aorta below the renal arteries, right? So you don't see any more of this white stuff down here. This is an abrupt occlusion of the aorta below the renal arteries. So this is the aorta here. You can see that this is the SMA. This would be the right renal, and then you don't see any more aorta. And the diagnosis is Lariche syndrome. What would you expect the other symptoms to be? Type it in the chat if you know. And let's
claudication.
Claudication. What's the other parts of the triad? Impotence and pulselessness, right? No femoral pulses and impotence. This did not play. Oh, maybe it will. Oh, I don't even like that. Okay, but just know, Dr. Gichoya is going to tell me hurry up right away. I'm not showing off at all, but this patient presented with hypertension. And yes, this patient has Lariche and they have, but their creatinine was very high. Because if you go back and we can look at this MR, you can see that, yeah, there's still a stenosis right here in that renal artery. So we were here to try to treat that renal artery stenosis, and there it is. So where did this catheter come from, right? Because we know the infrarenal aorta is occluded. Great question. So when we're talking about tracing the pathway of this catheter came from the left radial artery into the brachial artery, axillary artery, subclavian artery, into the descending thoracic aorta, like around the arch, all the way down past all those other vessels, you know, that we talked about, and then here into the left renal artery. All right, no showing off, just know that we angioplasted this and placed 2 stents. We were able to open it on the right and the left, and it doesn't matter because you can't see my pictures here, but that this patient did well. All right, I'm all done.
Okay, but there's a question. Was this patient having zero perfusion to the lower limbs?
What about that? How could this patient have zero perfusion to the lower limbs? If you have acute occlusion, should I go to the next slide, doctor? I thought maybe not. Oh,
because we're going now. You're gonna review.
I know, but it's gonna take. Won't be able to do all of this here, but okay. Maybe so we will.
I think you're the best person for lower extremity? Because
I am.
before,
I am.
before, I mean, Dr. Newsome was an IR, she was a surgeon.
I was a surgeon before.
And I just think I was trying to get us to review this, but we can also just come back to this like lower extremity, because we're just now at the iliac, right? We're coming down to the iliac, but could I see on the chart, we have probably around 10 more minutes. What's the interest of either pushing this to have a better detailed review of the lower extremity angiogram, or just complete it in 10 minutes?
We can try to do it in 10 minutes. I can talk real fast. So aorta, right? And then you have the right and left common iliac arteries, and then you will have the internal iliac arteries. But let me just go, globally say this. The images that you're looking at right now are exquisite MRA images of the aorta and lower extremity, as opposed to the image all the way on the right, which is catheter angiography. Now, I mean, very few people are doing diagnostic catheter angiography now because we have such great CT and MR imaging to show us the arterial anatomy. And I didn't spend enough time just yet to say what, to give my number ones, number twos, number threes. But if you will humor me, I will still do it right now. So I think we've done the anatomy in the abdomen, right? And if we come into the pelvis, as the aorta bifurcates, it bifurcates into the right common iliac artery and the left common iliac artery. We'll talk about that. Those will eventually be split into two, as you'd say, into the internal iliac artery and the external iliac artery. These are also called, the internal iliac artery are also called the internal, the hypogastric artery. That is an old nomenclature, but still people would refer to it as the hypogastric artery. When we talk about diseases that affect the uterus or the pelvis, prostates, pelvic traumas, those are typically vessels that get damaged quite a bit. The common iliac artery then becomes, again, the internal iliac artery and the external iliac artery. Around the level of the hip, it becomes the common femoral artery. And then the common femoral artery will become the superficial femoral artery and the profunda femoris artery. I have angiographic images of this, so maybe I just carry on here to show you. When you look at an image of the pelvis, right? So this is someone whose catheter is in the left side, left common iliac or common femoral artery puncture. And this is a catheter that has marks on it so that you can measure in centimeters gradations. You can image it in the pelvis. You can see the right common iliac artery, the left common iliac artery, and the frontal images, everything is quite superimposed. You can see the external iliac artery here where the catheter is, and branches of the internal iliac artery, such as the superior gluteal artery, inferior gluteal, and some of the obturator branches. I'm not going to go through that right now, just broadly that you can see the internal and external iliac arteries on the frontal image. This is an unsubtracted image. This is a subtracted image. This is an unsubtracted image. And this is the subtraction of the bone. All right, in radiology, we always say that one view shows you nothing, right? You've got to have different views in order to see. So I want to point out that this person has a blockage in the external iliac artery. But if we go back to the AP view, you really can't see that much. But in that same picture, as we get an oblique view, this actually shows the external iliac artery stenosis quite a bit. Not only that, it also opens up the bifurcation of the internal iliac artery and the external iliac artery on that side, right? So Dr. Gichoya may have a mnemonic that helps her to remember that. Maybe you shouldn't, right? But just know that in interventional radiology and radiology, we have ways of remembering, okay? But I will let her tell you in a minute. But that in one of these obliques, right, it opens up the bifurcation of the internal and external iliac artery on one side, and it opens up the bifurcation of the common femoral bifurcation with the profunda femoris and superficial femoral artery on the opposite side. All right, let me just recap that. Whatever oblique that you're looking at, right, it will open up the opposite internal iliac artery and common femoral artery bifurcations, right? Let's do that again. The oblique here opens up the bifurcation of the internal and external iliac artery on this side, but it overlaps the bifurcation of the common femoral and superficial femoral artery on the same side, but the contralateral side, it opens up the femoral artery. All right, I'll show you another picture of that. Now, if you look at the other oblique here on the same patient, here is the internal and external iliac artery, right? On the ipsilateral side, and then the contralateral side, it opens up the superficial femoral artery and the profunda femoris artery. Here is that stenosis again in the external iliac artery, okay? Pelvic obliques are critical when you're trying to determine where you have disease and what you need to treat. Okay, now this patient has a right common iliac artery occlusion. What do you think the symptoms could be? Because you know what blood vessels this is going to be supplying. Please type that quickly in the chat. What do you think this patient will be presenting as? What kind of symptoms with this patient? Claudication, where? I need sidedness.
Right or left?
Right or left claudication. Claudication of the hand, claudication of the pulselessness on the right side, right? Buttock claudication and right lower extremity claudication. Fantastic.
What is claudication?
What is claudication? Claudication is where you develop pain in the calf with or thigh with movement, and that pain that goes away with rest. So the issue is that you have a blockage in the blood vessel, right? And then when you start using your muscle that demands more blood flow and demands more blood flow, then that blockage becomes real. And now the blood is not, your muscle isn't able to get as much blood flow. So you develop pain in that muscle. But then when you stop, right, then the blood is able to find its different small pathways so that the muscle is able to be perfused normally at rest. But when there is any demand on that muscle, it creates that pain. That's the term claudication, refers to pain with exertion that goes away with rest, as opposed to the other state of this disease, which would be called rest pain, right? Where the blockage is so severe and there's not even any other collaterals getting to it. When you're just minding your own business, your muscles are still having pain because there's a severe blockage that is causing the muscle to not get enough pain even at rest. And then the third state of that occlusive disease would be someone that has tissue loss, where there's not even enough blood flow to bring enough oxygen at rest for the muscles or the tissues to remain viable. Then they break down and you have tissue loss. So this is, claudication is the beginning of the spectrum of peripheral arterial disease: claudication, rest pain, tissue loss. So defining claudication as pain with rest, pain with demand or exercise that must go away with rest. Does that answer the question? Yes. Okay, so this person has right iliac artery occlusion that we showed here, but if you continue to look at these images, right, the other side, the common iliac artery looks good, internal iliac artery is open, and here you can see all these pelvic collaterals, right, that is going around to reconstitute the external iliac artery back on the right side, and right up to the nub of that not internal iliac artery, in terms of the common iliac artery. It is only the ostium, or the origin or beginning of the common iliac artery, that is occluded. So, I mean, as you can imagine, this is something that we can fix, fairly easily with stenting. And here you can see that a stent is placed across the right common iliac artery occlusion, and Dr. Gichoya and I would be having a philosophical debate about kissing stents or not. All right, we're not going to do dissections here, but it's the same. As in the aorta, and those are treated with stent. Oh, fantastic, okay?
Are the black circles thrombi?
Or the black circles thrombi. So these black circles here, these are not the black, here. The thrombi. No, that's a fantastic question. This is referring to what we call a vessel on end. So if I did another oblique, you would see that this vessel would actually be able to be laid out a little bit more. So this is just projected on this image as if it's on top of each other, and so it projects as a circle. But once I get an oblique, you can see that vessel would lay out and it would no longer be a circle. That's the same for these other, smaller branches that you see here. These are not thrombi. These are vessels that are tortuous, that are just being seen in that projection, that you'll be able to, with another oblique, open that out quite a bit. Okay, so this person, by the way, has a left iliac stent in that is occluded, and you're thinking, oh my gosh, Judy, I don't have enough time to go through the collateral pathways.
Which is the answer to the Leriche
Which is the
syndrome, right? How was that patient perfusing
their legs? Okay, so I will try to.
I think we should stop and we will blackmail Dr. Newsome by giving her very sweet messages to come back and just talk about PAD, because this is a disease that you only understand if IR, explains it, because it's just so much better, and you can put up I don't know why I do that.
I'm not sure why we're having some,
Dr. Judy, can you turn on your mic?
They can't hear you, which is what I'm saying. So let me turn mine off.
I can just come.
Okay, right.
So I'm just saying that what we should do is I vote that we stop, because this is such a big opportunity to learn from Dr. Newsome from PAD. Really, it's something that even most of the new IRs don't do. When I went to train, we did them, but we don't do them here at Emory as much. And so I think for just a better review for the lower extremity, for even pathology, those things that, like claudication, tissue loss, healing, thinking about just wrapping things together, because that's really the lower extremity and the upper extremity. And then we'll have like a good wrap up of the arterial anatomy. Do you guys agree? Because I think we'd rather, instead of rushing through, do a good job to finish this, especially because, okay, so Walter is saying yes. I don't see people, Sheila is saying yes too. And
I agree with that. And maybe what I'll do is that I'll try to make my videos,
we'll
put
bring
that on
videos,
the videos, that way
right?
we can do that.
Okay, so most people agree. So I think I'll just spend 1 minute just sort of like recapping, and then we'll give Walter an opportunity to say something, and Dr. Newsome will be thinking of the final. Or maybe let's give Walter a few minutes to say something, and Dr. Newsome, and we'll share one last thing. We have some interesting cases, but
yeah. Thank you so much. Thank you so much, guys, for coming today. Thank you, Dr. Newsome. That was wonderful. Dr. Gichoya, amazing. You guys, we're doing very well. I think every weekend we have something coming up, and we're gonna look for time for Dr. Newsome to continue talking about the PDA pathology in the lower legs. And next week we'll have ophthalmology with Dr. Wanja Madenge. She will be going through ophthalmology, the good stuff, cotton wool spots, all those stuff that you might be thinking about that usually come to the exam. So be ready for that, look forward for that. Then the week after, we're gonna be having neuropathology by Dr. What was the name again? Dr.
Priya? She is a neuroradiologist actually at UCSF. So she kindly agreed to just come and talk about pathology. So, I think that's going to be amazing. She's also a foreign medical grad like me. So like us, really, except Dr. Newsome here, but but that's going to be good. I think as we, she's also an immigrant. It's okay. She thinks she's African, but you know, that's going to be good in terms of figuring out how to just having someone just go through like lots of cases. I think it's going to be good.
Yeah, so you see, we have Emory in the house. We have now University of San Francisco coming in the house from California. So we're creating a network. So you guys keep look for the emails for all these people. Send them messages, send them questions. You know, request something you need to be taught. And also after that, we'll do ECGs with Dr. Job Mogire from Kansas. So we have almost a packed September. I may not be showing up some of this time. My residency program is getting a little bit busy. So, but I know we have everybody, Dr. Newsome, Dr. Gichoya, they're always there for us. And we have many people out there who are there for us. So keep studying, keep being motivated, keep the spirit going. So that's all I have from my desk. Thank you so much.
Awesome. So we'll give Dr. Newsome a final word. Not too preachy.
Not too preachy. All right. So the final word for today, I didn't prepare one, but I always have one. And if you know me very well, most people would know that I actually have, I suffer from imposter syndrome, right? Where I don't always feel very deserving, but I'm on my journey for this. And I'm positive that as you guys go through your training, you will also have moments like this. And so there's a new term that helps me to overcome my imposter syndrome, that I don't think of myself as being superior, right? Superiority is when you, that in order to live in that world, then you have to put other people down, right? And inferiority, which is a world that I live in a lot, means that I put other people up, right? But if I can challenge you all to be on this journey with me, to live in the world of interiority, where your mood, what happens to you, is independent, Walter, independent, Lydia, independent, Doreen, and Eunice and Victor, of whether people are up or down, but it is 100% dependent on you, then you live in that world of interiority. And so come with me on this journey of lack of superiority or inferiority, but pure interiority. So thank you very much.
Okay, makofi na asante kwa Newsome. Bana, tunaenda election.
I vote for Dr. Newsome. All right. So thanks everyone, and have a very, very good.
Thank you so much, Dr. Newsome. I know you're super busy and you've made time back-to-back weekends for this. We really appreciate it. I do definitely appreciate it. I actually learned some new things too. And thank you so much, everyone, for your engagement.
Can you see that shared as schedule?
Yes.
Oh yeah, so if you can see that, that's what we expect. Few changes might be there, but that's what we expect in the couple of days. Thanks.
Yeah. Kwaheri.
Thank you. See ya. Bye.
Kwaheri.
Bye.
Bye-bye.